Great, Jim. Have we moved over?
Yes, sir. Sorry.
Great. Well, good afternoon, everyone. Welcome from the National Veterans Resource Center up here at Syracuse University. Thank you for joining us today. Also, thank you to those who've served, are serving, or are family members. We thank you for your service and hope you all had an enjoyable Veterans Day yesterday. We appreciate you all, especially those who are back with us yet again for our fourth iteration in our running webinar series in partnership with the Prevents Task Force, the VA, and our interagency partners at SAMHSA. I'm Nick Armstrong, and I head up the research and data analytics team here at the Institute for Veterans and Military Families. And as I've mentioned before, pursuing every possible avenue to work together better to prevent suicide is both a personal and professional matter for me and for our team here. It's why we're here today, and we all have a role to play. So it's an honor for us at the IVMF to partner with the Prevents Task Force to help advance the recommendations set forth in the Prevents Roadmap issued earlier this summer, and to do our part to promote this public health approach to curb this national tragedy of suicide. We've covered a lot of ground in our last three sessions. We covered in great depth the Prevents Roadmap, the REACH public health campaign, and initial steps states and local agencies and organizations can take to engage together. We covered Prevents and interagency partner priorities in working with states and communities. And we showcased examples of how states and communities are already engaging. And most recently, we heard from Prevents, VA, and SAMHSA leaders who covered how existing state efforts can better leverage the resources and tools that are available to them. Fortunately, if you missed any of these prior webinars, we recorded them and they're posted to our website. I'll ask my teammates here to drop a link in the chat dialog box for any of those who want to link back to that. Could we flip forward to our agenda? So today we've arranged a town hall, a little bit different format from our last few sessions. We brought our principals back together from the Prevents Task Force, the VA Office of Mental Health and Suicide Prevention, and SAMHSA, and given the incredible level of interest and the rich discussions during our prior sessions, we wanted to regroup once more for a town hall style sort of moderated Q&A. This is an opportunity to hear from you, to hear about your needs, your concerns, overcoming barriers to implement successful programs to stop veteran suicide in your communities, and really hear straight from leadership on those questions and concerns. You flip forward one. Thanks. Just a very quick note on the Institute for Veterans and Military Families. I'm sure many of you have been with us for prior sessions, but for those who may not, we're based at the recently completed National Veterans Resource Center here at Syracuse University. IVMF is higher education's first interdisciplinary academic institute singularly focused on studying and acting on opportunities to advance the post-service lives of veterans and their families. And though we're based at Syracuse University, you can tell by this map today, we physically operate in more than a dozen states and military communities across the country, serving close to 20,000 military-connected individuals each year through entrepreneurship education, in-demand career skill training and credentialing, community-based technical assistance, and research and data analytics. Next slide. So I'd like to introduce Dr. Barbara Van Dahlen to provide some opening remarks. It's my pleasure. Dr. Van Dahlen stood up the Prevents Task Force in early 2019 upon President Trump's signing of Executive Order 13861. She's led the effort to build this national strategy to prevent veteran suicide. She's a licensed clinical psychologist with a doctorate from the University of Maryland and over 20 years of clinical practice experience. Dr. Van Dahlen is also a former nonprofit founder and an executive, most notably of Given Hour, which is a national nonprofit that provides free mental health care to those in need, including service members, veterans, and their families. She's widely recognized for her work in changing the culture associated with mental health. She's a regular contributor to the Huffington Post, Time, and has been interviewed by about every major media outlet you can think of. She's been named to Times Magazine's 2012 list of the 100 most influential people in the world. And with that, I'd like to turn it over quickly to Dr. Van Dahlen to provide some opening remarks.
Yes.
Thank you so much, Nick, and huge thank you to IVMF for this series. You know, the work that we're doing through Prevents with our partners like SAMHSA and the VA and so many of the organizations who are on this call, state and local efforts. You know, we can't achieve our goal by ourselves. We know that. We knew that from the beginning. That's why Prevents is an all-of-nation, all-of-government effort. And these kinds of opportunities are hugely valuable to us. So I want to thank IVMF for your partnership. It's been great fun to get together with some of the folks that I work with closely in this work for these presentations. And I'm just really extremely grateful, as I know my whole team is. So huge thank you to IVMF and also to SAMHSA and to VA for joining us in this series. Incredibly valuable information. And we hope that it's useful and inspiring in addition to engaging. So next slide, I'm going to share a couple of updates before we get to the Q&A. And I want to talk a little bit about our REACH public health campaign, because there are a couple of updates I want to share. And as for those of you who have been on these before, you know that REACH is the national public health campaign that we launched in July. This is the logo. This is the tagline, "We are all within reach," which we believe. I'm proud to say that since we launched REACH back in the summer, we have created over 2.5 billion with a B impressions and a number of ads and images that many of you have probably seen on a splash page or website that you visited recently. We have some new elements of REACH that I want to highlight, because these are things that you all can partner with us in your communities, in your states. You know, we have the state proclamations with 42 states and 1 territory, and you can find, you know, if your state is one of those, by visiting us on our website at va.gov/prevent. So please, you know, take a look and see. But we want to work with you regardless, because we're going to get every state involved as we continue our visits, and I'll talk a little bit about that at the end of today. But when it comes to REACH, you know, we're educating the country about risk factors, protective factors. We're dispelling myths. We're having conversations with leaders, our ambassadors. Just this, in the last couple of weeks, former Secretary of the VA, Bob McDonald, has come on board to be one of our ambassadors. And we have a new ambassador coming on, another person with a massive celebrity reach that will be joining. I just can't announce her yet. Soon. We're probably next week, you'll see that. So follow us, watch what we're doing. And I'm going to show one of our videos in a moment, just as a reminder. But 2 things that we're working on now that I really want to call out. One is a video campaign that we're driving, and it's called Moments to Reach. And this is something that everyone can do. We want everyone to do. And you can go to our reach.gov website and learn about what we're doing. Basically, we're asking all Americans to share a 2-minute video. Make a video. You'll go to our website. You can see the one that I did, A Moment to Reach in my life, when someone actually reached to me that allowed me to reach to someone else. I won't be a spoiler. You can go see the video. But I did it sitting right where you're looking at me now. It was very easy to do. These are basic, you know, smartphone videos. And we're asking everyone to do this video, either telling a story where you reached out to someone in need reached out to you, or you reached out for help yourself, and what happened. We want to share the message that we are all within reach. We all have struggles. We can all be part of the solution. Bob McDonald did one of these for us. You'll see that soon. We're running this ongoing, so please push this out. Help us get the word out. Use it in your own efforts. They can be moments to reach in your state, in your community. That's one. Second thing that you'll see coming soon is our holiday messaging. We're very concerned about the impact of COVID on the emotional health and well-being during this holiday season. So we're launching a special, we do this, you know, we have these campaigns within the big campaign. So you'll see that coming. So look for that. And again, if you want to partner with us on any of these communication opportunities, please reach out to us. So now, before we get into the moderated discussion, I'm just going to ask to show this video. Some of you have seen this, just to give you again a reminder of what we're working on through REACH. So go ahead with the video. I love that video. I've seen it. I don't even know how many times. It still chokes me up. So this is what we're working on. We believe everyone is in reach. And one way we want you to help us is to promote the Prevent Pledge to Reach. We now have over 12,000 people who have taken it, and the number keeps going up. You can help. And we also have an organization pledge. So if your organization wants to take a pledge with us, we have that as well. So with that, I'll turn it back to Nick, and happy to get started with this exciting conversation and Q&A from some of our experts who are partnering with us to do this work.
Excellent. Thank you. So I'd like to introduce two more of our distinguished panelists here who are with us today. First, Dr. Richard McKeon. You could flip to the next slide. He serves as the Suicide Prevention Chief at SAMHSA Center for Mental Health Services. There he oversees all suicide prevention branch activities, including two major grant programs focused on youth and campus suicide prevention. He oversees the National Suicide Prevention Lifeline, the Suicide Prevention Resource Center, and the Native Aspirations Program. He spent most of his career working in community mental health, with 11 years as director of a psychiatric emergency service and 4 years as associate administrator director of a hospital-based community mental health center in Newton, New Jersey. He was awarded the American Psychological Association Congressional Fellowship and worked for United States Senator Paul Wellstone, covering health and mental health policy issues. He served on numerous boards, including the American Association of Suicidology and the American Psychological Association. He served multiple cabinet secretaries with appointments to VA's Blue Ribbon work group on suicide prevention and the DoD Task Force on Suicide Prevention in the military. Dr. McKeon is also the co-chair of the Federal Working Group on Suicide Prevention and has played an active role in strategic planning for our national strategy, as well as with the World Health Organization's World Suicide Prevention Report. And he received his PhD in clinical psychology from the University of Arizona and his master's in public health from Columbia University. Our other panelist is Dr. Lisa Kearney. Dr. Kearney is the Deputy Director for Suicide Prevention and Acting Director for the Veterans Crisis Line for the U.S. Department of Veterans Affairs. Her work focuses on the development of VA's comprehensive health approach to suicide prevention and overseeing the day-to-day operations of the crisis line and suicide prevention. Dr. Kearney recently served as Associate Director of Education at the VA Center for Integrated Healthcare, based up here in upstate New York. Previously, she worked nationally as part of the executive team in the VA's Office of Mental Health Operations, overseeing mental health policy implementation through quality improvement, site visits all across the VA system. Locally, Dr. Kearney has served as the Chief of Psychology, Assistant Chief, Director of Training, and Director of Primary Care, Mental Health Integration at the South Texas Veterans Healthcare System. There, she is also a clinical associate professor of psychiatry. She serves in editorial roles for several prominent scientific journals in her field, and is currently the president of the American Academy of Clinical Health Psychology. And she's a graduate with her PhD from the University of Texas in Austin in clinical psychology. So welcome back to the three of you. If you want to jump right ahead. So as we mentioned at the top, today's session is really a town hall style. We're really trying to drive toward a conversation between our panelists and with all of you who are on the call here today. So I really encourage those of you who have questions to pop those in our Q&A section. We're monitoring that. We've taken the time to consolidate a lot of the questions that have come up through our past discussions in the last 3 sessions, and have pulled many of you in terms of what's on your mind. Try to really organize those into a handful of themes to help guide this discussion. Really 4 themes that kind of came up in terms of the questions themselves. First was around crisis intervention. Another topic is around funding and resourcing at the local, state and local level. Another is around the implementation, sort of operations and structure between the agencies and engagement with state and local organizations, and then analysis and reporting, like how data is being used. And so what we're hoping to just dive right into some of these themes. And again, if you have questions that you would hope to have any of the panelists elaborate on, I'd ask you to drop those in here and to the panelists. So while we'd really love for you to kick this back and forth. So really just diving in with some of the crisis intervention questions. I know we've got a couple panelists who lead national crisis lines. We can start right off with the most critical question of all: what should I do if someone tells me they are thinking of suicide? And maybe I'll kick that to Dr. McKeon to start.
Yeah, thank you. That is a critically important question, and something where we would want every American to have an understanding of what to do. So this is what I would suggest. If you are talking with someone, you find out that they are thinking about suicide, or you suspect that they might be. First off, it's okay to ask the question of whether somebody's thinking about suicide. A lot of times we don't, because we are understandably anxious, because we don't know what we would do if the answer is yes. But anytime you ask that question, you have an opportunity potentially to help overcome what may be some tremendous isolation for the person who's thinking about suicide, who may not have shared that with anyone yet. So the first thing is to be willing to ask the question. And then when you get a response, if the person is thinking about suicide, it's important to not panic or to back away, but to be there, to listen and to talk to the person, right? Now, if somebody's thinking about suicide, we want to be able to connect them to help. And so that is vitally important, to be able to do that. It's also important to be aware that not every time somebody has a suicidal thought does not mean that the person is at imminent risk of acting on it, right? So it is not necessarily always an emergency. So you can take a moment to talk with the person to find out more. There's all kinds of trainings that are out there. Train people in the community, things called gatekeeper training. The VA uses a SAVE training. There are things like assist and safe talk and question, persuade, refer that many communities have utilized. But it is important, before ending the conversation with the person, to be aware of how to reach out for help, particularly pretty much under all circumstances, but particularly if there's an urgency because there's concern the person might be thinking of acting on these thoughts, very soon. And there, I think the most important thing to be aware of is there are options between walking away on the one hand or calling 911 on the other hand. The National Association of 911 Administrators have recommended that 911 be called when somebody's making a suicide attempt. And there may be other times when the person appears likely to, in the very near future, meaning minutes or the next hour or two where such a step might be needed. But if not, an important approach, if you're interacting with someone who's thinking about suicide, is to call the National Suicide Prevention Lifeline at 1-800-273-TALK or 1-800-273-8255, where if the person is a veteran or concerned about a veteran, they can press 1 to be connected to the Veterans Crisis Line. It's also important to be aware, although it is not nationally available yet and won't be universally available until July 2022, 988 will become the new National Suicide Prevention number. Again, that will be easy to remember anytime that there's an issue around suicide. There probably will be more conversations at that point about when to call 988 versus when to call 911. But it's important to be aware the National Suicide Prevention Lifeline is available at any time in the day or night, anywhere in the country, if somebody is thinking about suicide. And the person who answers that phone is going to be able to help steer the individual themselves or a loved one or a friend on appropriate responses. It's also important to be aware that promoting the 1-800-273-TALK number is always a good idea, because even when 988 becomes fully operational, 1-800-273-8255 will continue to be a number that will connect to the National Suicide Prevention Lifeline. That will not be shut down. That will always be available, as well as the number 988. So thanks. And I'm happy to turn it over to Lisa for things she might want to add.
Richard, I really loved that you spoke about don't back away if someone answers that they're thinking about suicide. And I think it's something that we need to begin to normalize in our culture, is being able to talk about suicide more openly, and that we're all at risk. And that's one of the things I love about the Prevents Reach campaign as well. Being able to talk openly about it. The more we talk about it, the more we normalize the discussion and realize we can all be at risk at different times. And I would say to folks, be attentive to risk factors that may be at hand, and they may differ for different individuals. So for some that it may be you're noticing actual feelings of sadness, depression, they're just not themselves that way, or they may be reporting sleep problems, they can't sleep. But others, it's more tricky. The technical term for it is what we call anhedonia, but lack of pleasure in things, right? So if you have an avid football fan who normally is talking about everything going on with the games, and then all of a sudden is just disengaged and not talking about those things and kind of withdrawing from people, that's going to be a different sign for them than it may be for someone else. So I think the important point is, even if you're uncomfortable, it's okay. Go ahead and reach out. Ask the question, and then be able to connect them with the resources. And I'm glad, Richard, I think he said the number 3 or 4 times, 1-800-273-8255. I'm so glad. But what I encourage people to do now is put that in your phone. Just store it in your phone so you have it available, and that you can also share that contact with other people that you're having concerns about.
Thank you, Dr. Kearney. Looks like we have that number and the link to that in the chat here for those who would like to input that. But just a piggyback on that question too, does eligibility matter in terms of considering these? I know we had some questions come in around, if a veteran may not be eligible due to a different discharge status, how does that play here with respect to the crisis lines and VA?
Well, one of the things that I'm grateful for with the Veterans Crisis Line is available for all veterans and for those who are supporting loved ones who are veterans. It's available to anyone. The eligibility is irrelevant when you call the line. You are going to have a responder be able to answer and assist you. They'll also be able to connect individuals with resources outside the VA as well, if they're not eligible. But I think people are often don't understand there are actually particular policies that help individuals who are not eligible in times of crisis. For example, we have a directive about eligibility determination that says if there's an emergency situation for an ineligible person, they can have an episode of care up to 90 days. So realize when you call the crisis line, they will be able to connect you either within VA or outside of VA. We're here to support you. Don't keep that from having you call the telephone line.
Terrific. Thanks for that clarification. Maybe just shifting on this same topic, and maybe over to Dr. Van Dahlen, some questions have come up around lethal means. I know this is actually a key piece in the roadmap. Maybe you could talk a little bit about, and then we can pass it around just in terms of how we're thinking about addressing lethal means and access.
Thanks, Nick. That's a really important, and it fits really nicely with the prior question, which is, one of the really driving beliefs and goals of the work that we're doing with Prevent and Reach is to change the culture around these concerns, these issues. We need to make sure that people get more comfortable talking about, I'm not feeling right. Well, what does that mean? Well, I'm actually having some really scary thoughts. We want to hear from people who are struggling before they're at a point of choosing a lethal means. So this all fits together, this notion of helping people to be more mindful, educating them about how to talk to people. I just posted on the chat, we're going to actually be putting out a tool focused on how to reach, because people may see someone that they're worried about and not know how to have that conversation. They're afraid, they're embarrassed, they're uncertain. So that's something that will be coming in early 21. And in terms of lethal means, this is another one of those very hot button topics that people often have a great deal of concern about, especially when it comes to firearms, and especially for our veterans or our first responders, who it is very much a part of their identity. I think about my dad, who was a veteran, lifelong NRA member, my brothers, who both have large collections of weapons that they use for hunting and shooting. They go to the firing range. It's part of their sort of R&R, if you will, that they do with their sons. And so it's really important that we differentiate. When we talk about lethal means safety, we're not talking about removing anyone's means, whether it's medications or firearms permanently. That's not what this is about. It's not about preventing anyone from owning firearms. In fact, on the other side of the coin here, when we talk about people who have mental health challenges, we don't want to further stigmatize them or further treat them as if they're not able to enjoy some of the pastimes. But we do need to make sure that we're having conversations about building in space and time. When somebody is at high risk, when someone is contemplating ending their own life, we know from good research, that if they have more access to a lethal means, then that increases the likelihood of that action. We want to do whatever we can. We want to educate. We want to have these conversations. We want to provide trigger locks for firearms so that it takes a little longer, give somebody time to think. We want to educate family members. We want to think about working with pharmacies and pharmacists and physicians around medications. We want to work with families so that they understand how teens and younger than teens might use the website to sadly do research to find out about how to die by suicide, so that they can monitor that, they can look for those signs. So this is, hopefully people can hear, this isn't about taking rights away or taking firearms away. There's some great efforts that are happening with some of the first responders, some of the police departments that we've been working with through Prevent, where they've made adjustments. So rather than taking an officer's weapon and badge away, they temporarily remove the weapon, but the individual keeps his or her badge, because it's part of their identity. So we understand we've gotten more sophisticated and sensitive. So I would say this is the It's not a simple conversation. It's complicated, but we need to keep having it. And we need our veterans organizations to keep educating their members to help them understand that's not what this is about. It's not about removing anyone's right to bear arms. It's about making sure that when people are at risk, we make sure that their weapons are secured safely so that they are not able to act on that impulse, because we know that if we break into that pattern, the great likelihood is after that crisis passes, they will not want to have died. They will be glad that they didn't die. So I'll stop there, and I know Lisa will have other thoughts as well.
Yeah, Barbara, I'm so glad that I just hear your passion with this, and I completely agree. And it's a hard conversation though to have. I was reflecting back. My dad just lost a dear friend to suicide. My dad's a veteran as well. And I was recounting with him what happened before he lost his friend, just a dear man. And this gentleman was going through some difficult relational issues. There was stress. And my dad actually asked him, "Can I take your firearm for a little bit of time?" And ended up, he did not let him take the firearm at that point. And it's something that goes through, I know my father's head all the time. It's like, should I push some more? But I was proud of him for asking the question. But, he even shared with me, it's difficult to ask that question. We've got to get comfortable with moving that, because you don't know when someone is in that state of mind. It's just a split-second decision. And we know that if we can give a little bit of time and space, people are more likely to not do that. And what a statistic that always is near to my heart is people actually who survive other suicide attempts, 90% of them go on to not have die by suicide. I mean, we can prevent suicide by providing this, but we've got to get comfortable talking about these things and helping communities talk about these things.
And if I might, just, we think about the movement we've made when I was growing up. Sadly, we lost a lot of young people to drunk driving, and Mothers Against Drunk Driving and other efforts started to really focus on, the whole concept of designated drivers. Friends don't let friends drive drunk. It changed the entire culture. It changed the way we function when we're with people socially and people are drinking. We have in our head a different way of thinking. Similarly, when we think about people who have physical challenges, somebody who is impaired physically, we wouldn't ever think it would be okay to put them in a situation where either driving or where they weren't able to make a good decision about the medication they should be taking. We haven't yet made that leap, if you will, when someone is in an impaired state of mind because they are in such stress and are so overwhelmed and feel so hopeless and are not able to see that there is another way. Why don't we afford them that same level of sort of thoughtfulness, sensitivity, and protection? Because they are not in a place to make that decision and they're not in a place to know what they can and can't handle or manage. Just like we wouldn't let somebody who was impaired because they'd been drinking too much get behind the wheel of a car.
Dr. McKeon, I don't know if you had any points or comments to discussion around.
I think that both Barbara and Lisa have made some very important comments. I think that these are challenging conversations to have, but they're incredibly important conversations to have. And I think that there has been progress that's been made in a number of areas, and there have been resources that have been developed. So for example, the Suicide Prevention Resource Center has a free online training available called CALM, or Counseling on Access to Lethal Means. And this is particularly useful for providers to take a look at about how to have some of these more challenging conversations. that can respect where each person is coming from and their feelings about firearms and firearms ownership and firearms storage, etc. Also communities have done more to deal with these issues. In a number of states like New Hampshire and Colorado and elsewhere have moved forward with something called the gun shop projects, which have really worked with gun shop owners as partners in trying to reduce suicide prevention. And even on state policy levels, in the state of Washington, for example, Jen Stuber at Forefront, one of the leading suicide prevention advocacy organizations there, has worked closely with a range of stakeholders, and they have passed legislation which basically aims as getting together all of the people who have an important voice in the conversation about access to lethal means, including the National Rifle Association, including pharmaceutical companies, because of the issue of pharmaceuticals being used in fatal and non-fatal overdoses. So there's a lot of very important work that is going on. But I really agree with what Lisa said and what she shared about her own family experience. It's more than asking someone, for example, to remember a phone number. It's helping them be prepared to have some potentially challenging conversations and challenging in terms of their own anxiety, but very, very important conversations to have. So thank you for the opportunity to weigh in on that.
And if I might, one other thing that just brings to mind, one of the, as I think folks know from these conversations, we're really big on partnerships. And one of the partnerships that we now have is with the American Psychological Association. And next week on Wednesday is the first of a two-part series that is a free training for mental health professionals focused on suicide assessment, risk assessment. And I've asked Liz Barnes, who's on this, she's my deputy for Prevent, to post some information in the chat. And this is free, where it's part of our work to educate all mental health professionals and eventually healthcare professionals and eventually other professionals about basic skills to assess, to have these conversations. So I just want to call that out because it's free. And if you miss it next week, it'll be something that you can download, and we're going to have information about that we'll post and push out. But that's just another opportunity because we assume that our healthcare professionals and certainly our mental health care professionals should all be properly trained, but they are not. And so part of our work through Prevent is to move this forward with our partners like APA and VA and SAMHSA. And that includes these tough conversations. I cannot tell you how many times I've talked with another mental health professional about this issue about lethal means and how they felt so awkward and uncomfortable talking to a family that they were trying to deal with someone who might be at risk for suicide. So this is a great conversation and really important. So we'll continue to push out additional resources.
Thank you all. Such an important piece in terms of responding to crisis on this topic. We're starting to get some good questions in from the audience. One connected to the lethal means, but actually the two coming from Travis that I think actually raise a bigger question back to Dr. Van Dahlen. Two questions really related to active duty, those who are in service. Maybe one question around returning firearms to active duty service members, and other in terms of dealing with the command climate in terms of providing support. Could you maybe talk a bit about how Prevents relates to DoD efforts, and maybe how what someone who may still be in service and dealing with these challenges might want to consider?
So our partner for the REACH campaign, our communications strategy and also implementation partner is DoD. So we are working very closely in lockstep with DoD, just like we are with VA and SAMHSA, And DoD, the leadership at DoD has been very, very concerned about navigating, managing the same issue. And so you will see coming out of DoD and Prevents shared messaging, the same kinds of trainings and really starting conversations and leadership stepping up. One of our new ambassadors is Admiral Hancock, who is very open about he's a physician. He's also been extremely open about the trauma that he himself experienced through his service. And he talks very passionately about we have to have this conversation about lethal means, about weapons, about using firearms. And so I think we are there is no one single answer. And I'm happy to get more information for any specific question. I'm not sure if there's a specific question attached that I may not know the answer about, because obviously it depends on all variety of specifics for an individual service member. But the effort itself is well underway. We're going to see many more conversations and more advocacy from our leadership talking to service members and families. Mrs. Milley, who's the wife of the chairman of the Joint Chiefs, is another one of our ambassadors. And she wants to reach the service members' families to have these conversations, because it has to be okay if a spouse says, look, I see that you're struggling. I see that you're having a hard time. We have to talk about what to do to keep you safe, because I love you, because I care about you. And we have to have support from leadership so that that individual feels like that's okay. Again, equate it to a physical challenge. We wouldn't say to somebody who had a broken leg, well, hope that gets taken care of. In the meanwhile, continue doing everything you normally would do. No, we would make sure that they were treated and that their leg had healed, and then they would be going back to their regular duty. So Admiral Hancock, he loves talking about, he says to people, look, I'm an admiral. I have a service dog. Clearly, my invisible injuries and what I had to do to heal didn't prevent me from becoming an admiral. So that's where we're heading. We're not there yet, but that's the work we're doing.
Thank you. So the next question actually helps move us into implementation. A great question here, really sort of highlighting that, not all veterans are receiving VA care. So how are we looking to expand our reach into communities and neighborhoods across the country to engage directly with veterans? What cities and organizations have we observed as effective enhancing outreach within those communities? And what about their outreach was effective or are we seeing as effective? And I think it really sort of dives into like what's going on between all the prevents activities, VA, SAMHSA, and our engagement at the state and local level. So maybe you could start, Dr. Van Dahlen, but I think there's something here for everybody.
Absolutely, and I'll kind of go big, broad, and then let Lisa and Richard sort of talk about some really great specific stuff that's happening. So from the prevent side, we, as I said, sort of starting this out, we can't do this. No agency, no organization, no office can do this work alone. And we are determined to do our part to connect dots, to create a big tent, to bring everybody in, to look for how we can leverage and coordinate across agencies. Literally while I've been participating here, I saw a text come in that we're about to get one of our action officers from the Department of Labor who will come and join the prevents team. We already have 4 from DoD, and we'll soon have a couple full-time from HHS. And we have several from VA. So that work extends into the communities, and how do we identify opportunities through the Governor's Challenge? And I'll let Richard talk about that, and Lisa as well. And one of the things that Prevents will be doing in the next several months is creating a tool that will live on our sites, the va.gov/prevents website, and also Reach, so that community members can see what is being done in other communities, an opportunity to gather. These aggregated efforts are done in various places, and they're all useful. So we're going to continue to lift that up because we have this national platform to do that. And the other thing is, I'm really proud of the fact that we are working with VA, with HHS, thanks to the legislation that was recently passed S785, that will allow VA to have the authority to fund in communities. And the VA, I'll let Lisa talk about some of that, will be doing some funding based on specific focus that comes out of their suicide prevention program 2.0. And Prevents will be working with HHS to enhance, to support, to bring additional funding in to support Governor's Challenge states and community work that's happening there. So hopefully folks can hear that at the Prevents level, we're going to continue our work to gather, to bring together, to coordinate, to elevate, to amplify, to showcase, and work specifically with the agencies to bring resources into communities. Last thing I'll say, Lisa will talk about VA funding. What I can tell you is that any funding that comes from under the Prevents umbrella will require collaboration and coordination to be baked into the plan. We won't be funding, we won't look to fund programs that are saying, look, we can do it all. This is a one-shot deal. No, it has to be the coalition, the coordination, because we know that that collaboration is key at the community level. So I'll stop there.
So this is Richard McKeon from SAMHSA. I'd be happy to go next. The SAMHSA has worked closely with the Veterans Administration around the governor's and mayor's challenges. And these have gone on for the last several years. They are continuing this upcoming fiscal year that just started last month. So we are really pleased to be able to work with the Veterans Administration, with states and with cities to try to promote a comprehensive effort to reduce suicide among the nation's veterans. And particularly important because we know that the majority of veterans who die by suicide are not currently receiving VA healthcare. So it takes all of us working together to reduce veteran suicide nationally. There have been some wonderful things that have come out of these efforts. For example, in the state of Montana, one of the things they identified as a gap was in crisis situations. There was an absence of mobile outreach services that could go to a veteran or another Montanan, if needed. And advocacy that came out of that led to more widespread mobile crisis outreach services in Montana, not only for veterans, but for everyone else. And then we are also aware, and I'll turn it over to Lisa, that with the new legislation, there's now the opportunity to actually bring resources into these states and cities to be able to do this kind of work. So I'll turn it over to Lisa.
Yeah, we are very excited about that. That is the passing of the Hannon Act that just happened at the end of October, and it will allow us grant-making authority to help fund other agencies and individuals who are going to be strategizing to reach out at the community and state levels within their particular regions and expand our reach, which is just incredible. So we are delighted to be setting that up in partnership with Prevents and working alongside Richard and his team in SAMHSA as well. I think the other thing to talk about here is that VA is moving and has been since the publication of the National Strategy to Prevent Veteran Suicide, which is built off the national strategy overall. That was published in 2018, and you can really see that focus on reaching out into the community. We've really operationalized that into Suicide Prevention 2.0, which is combining community outreach and prevention also with our clinical services within VA. Governor's Challenge is a huge part of that, but also we are advancing our Together with Veterans program, which is incredible, based out of our Rocky Mountain MyRIC. And it's reaching out to rural veterans to train them in strategies for suicide prevention. So training veterans to reach out in their local communities and devising strategic plans along those lines. And then we're funding also, we'll be reaching out to 6 more of our regions this year to fund them. We've already funded 4, and eventually we'll get to all 140 healthcare systems in VA to fund what we're calling community engagement partnership coordinators, whose job will be outside the VA system to reach out, to coordinate with Governor's Challenge, to coordinate with rural veterans and their communities, to coordinate with local systems and build off those partnerships. And really, we have three major focuses in all of that work in the community. It's increasing identification of veterans and family members within the community, and increase the screening for suicide risk in particular, and promoting that outside the VA system as well in primary care clinics locally. We want to improve connection within the community with some of the crisis response you just heard Richard talk about, and improve care transitions between different levels for the needs they need. And then lastly, we'll be continuing to promote safety planning, as well as lethal means safety within the local, state, and national levels as part of this outreach.
I think, Nick, you're muted. Yeah, you're still muted.
We can't hear you, Dr. Armstrong.
There we go. Sorry about that. A couple questions coming in specific to the grants opportunities and in funding. So maybe could we talk a little bit about just how folks should be thinking about that? I know Dr. Van Dahlen, in the past you talked about a grants database, as well as the new legislation that's coming. I don't know if we're in a place yet, but just in terms of how should communities be thinking about different opportunities to fund their efforts?
Well, I would say that, I would love for folks to, go on and to our website and make sure that you sign on to our Gov Delivery, to the opportunities we have available for us to push information to them. You can, sign up with us when you take the Prevents Pledge. And that way we can push information, because there's going to be a lot of things that are coming in the next several months. It takes a while now that the legislation was signed. As some folks know, it takes a while to do the regulations and the rules that allow us, but we are committed, and I am driving as hard as I can drive, and I know that Lisa and others are as well, to get things done so we can implement and start getting funding into communities. But even before that, Prevents will be posting these tools that allow communities to see, oh my gosh, there's an opportunity that I could apply for that I didn't know I was eligible for. So that will come even before we start looking for the opportunity to bring additional funding. And then these tools that we're creating that will allow folks to identify either other coalition models that they can use. And the reason we're doing that is that we know that it's so much easier to get this work done if you are working with partners and collaborating. And especially in this day and time, we are really promoting to funders, look for organizations that are working collaboratively. When I was running Give an Hour 10, 12, 15 years ago, that was an anomaly. Or funders did not like, they just wanted to fund you. Tell us what widget you're making or what you're doing and we'll fund that. We've pushed back on that for 15 years, and funders are now understanding the importance of collaboration and coordination. So we are going to help continue to drive that into communities. And again, the best way for us to make sure that we communicate with you and you with us is join us, make sure that we are connected, so that whenever we push information out, you're getting it.
Thank you. Another question around data. I know this is also a question that's drives to like all that we're focused on, particularly at the IVMF, but some questions here around data sharing agreements between organizations. And I know evaluation is a huge piece of the overall Prevents strategy and roadmap. Can you talk a bit about thinking about what more we can do to help local organizations, federal, state, and local, share data,
yes.
And how to drive towards standardization with respect to all that? I know it's a huge topic, but we only have a few minutes.
It's an important topic, but what I'll say is it is a huge topic. It is an important topic to us, and we will continue to, at the federal level, break down barriers, and we're already forming agreements. And actually, COVID has been, sadly, I wish it had never, happened to us, but because of it, data sharing at the federal government level across agencies is actually becoming easier because there was a need to share data. So we're leveraging what we can that is being done as a result of COVID. So that's federal. But at the local level, we need to work with our state and local champions, our advocates. Prevent has our national ambassadors, but we also have state ambassadors. And those state ambassadors, we want to work with them. And we have regional champions who are connected to the SAMHSA regions that we're working with to drive policy that will change some of the current policies or remove barriers, because every community does their data gathering differently, and there isn't the consistency that we need. So if you're excited about sharing of data and you're driven, please reach out to us and we will work with you to bring our platform to help you, because we need that consistency of data. Otherwise, we can't tackle this as effectively. We just can't. But we got a long way to go, but we're working with CDC and our other agencies, VA, DOD. Everybody understand it's hard work, but it's important work. And at the local level, there's much to be done that people can be champions, and we can help you with that.
Thank you. And I know our friends down in New York City are saying they will absolutely reach out.
Good. I saw that post.
As we will. I know we only have a few minutes left. Dr. Van Dahlen, I want to give you a chance to talk a little bit about state visits and scheduling, but is there anything else that we have not addressed or that you'd like to put on the table, given where we've been over the last four sessions?
Well, I just want to say thank you to everybody who signed on to be part of this. I think there's a lot more discussions, a lot more conversation we could have. And I'm going to go out on a limb here and say that if there's an interest, if people share with IVMF through this platform that you want to hear more of these kinds of answers and more discussion, we'll schedule another one. I think we know that people want information and that information is powerful. So if there's an interest, because we covered a few topics, but there's more to talk about, there's always going to be updates. And you are our partners. You are the ones who are doing the work. And so I will volunteer my colleagues from VA and SAMHSA to come back again, and we can bring DOD to an upcoming conversation. So I assume that IVMF will work with us to do this if there's an interest.
Thank you. Over to you if you'd like to say a few words.
Yeah, so let's go to the next slide. So this is really what, that one. This is really what we've been talking about this entire hour, which is, this is about working with all of you, faith-based communities, first responders, state and local government, and nonprofits, veteran and military communities, Native American communities. These are the folks that we regularly sit down with when we do a state visit. We have visited already 7 states thus far, and we already have scheduled North Carolina, South Dakota, Rhode Island, and more are pending. So, if you haven't been visited, or if you have been visited and want to make sure that we, know about you, even if you didn't meet with us when we came, and we're doing these now virtually, let us know. Reach out to us. And Deputy Liz is on this, has been on every one of these, and we'll take back questions and feedback and follow up. So we're very excited about the state visits that we're doing. Next slide. And this is our approach. We really want to assess the need for mental health and suicide prevention programs by surveillance and implementation data that we can gather and work with you at the state level. We want to share that. We want to make sure that different states that may not know about the work that you all are doing, but that is similar, can be coordinated and connected. And that's that tool that we're building that we've talked about, that we're really excited about, so that you'll be able to go on, and learn about what's happening and make those connections, introduce yourself to someone else in a neighboring state or across the country that can work with you in a similar way. Join forces on the data. Do lobbying and do policy work together. We hope to be coordinating some Hill visits in the future around the data gathering. So we want to look for the opportunity to build capacity through coalitions. It's what the funding that we're talking about. That's what we're looking to do. And then we want to plan, implement, and evaluate the effectiveness of programs. We talk about this notion of a commitment to process. That's what this means. We know that you all are doing amazing work. We need you to join together with us and say, okay, how does that amazing work lead to empowering veterans, preventing suicide, growing healthy communities? So it's the process that we want to share, and sharing metrics. How do we measure? What do we measure? And then finally, sharing the information across stakeholders and decision makers. Next slide. These are our handles. Please follow us, reach out to us, talk to us, tweet at us. We just did a Twitter chat on Tuesday. We're doing another one next week on Tuesday, focused on caregivers. This past one was focused on veterans. Join us, talk to us, tweet at us. Next slide. I think that might be the last one. And here we are. Please reach out. Let us know what you need, how we can help, how we can partner. Thank you for joining. Thank you again to IVMF, to SAMHSA, and to the VA. We have tremendous partners. This is an amazing effort. I could not be more humbled and proud every day to do this work. So thank you all for being part of the solution. Together, we will prevent suicide. Thank you, Ilario. Thank you, Nick. Thank you, Lisa. Thank you, Richard. Thank you all for listening.
Well, on behalf of my IVMF colleagues, I'd like to thank Dr. Van Dahlen, Dr. McKeon, Dr. Kearney for their time today. We really appreciate your expertise and your leadership and partnership on this critical challenge that we're all tackling together. I'd also like to thank our audience, all those of you who are here today, and the hundreds who actually participated through the last three and today who joined us. You guys are the ones who are making this happen every single day. So while this concludes our initial learning series, we are looking ahead to 2021 to check back in with you all and to continue this discussion. So just a final reminder, we'll be posting this session alongside our previous three on our website. It's linked here, but please feel free to reach out if you have any questions. So thank you all and have a great afternoon.